Hello and welcome everyone to APHA's weekly webinar series addressing the COVID-19 crisis. Welcome. We're glad that you're here today. I'm Michael Hogue. I'm president of the American Pharmacists Association and dean and professor at Loma Linda University. And we have got such an exciting program for you guys today. I cannot wait for you to hear from these speakers. They are very engaging. Today we have with us, we're going to focus on highlighting frontline perspectives. You people who are in the same position that you are, who are dealing with the COVID crisis from the front lines, managing pharmacists, pharmacies, hospitals, all the things that go into COVID-19, you're going to hear from your fellow frontline providers. And I think this is going to be quite an engaged discussion. We have two special guests with us today. Both of these individuals happen to be members of the APHA Board of Trustees and are very active in the front lines of pharmacy practice. Dr. Alex Varkey, who's Director of Pharmacy for Houston Methodist Hospitals, will lead us off today, and then he will be followed by Dr. Randy McDonough, who's co-owner of Towncrest Pharmacies and Towncrest Compounding Pharmacies in Iowa. He will be telling us about his experiences from a community pharmacy perspective. And then just like every week, this week we'll be joined by two very brilliant APHA staff members, Dr. Dan Slott, who's Vice President of Professional Education at APHA. And as you all know, Dan had a long career with the NIH and worked in infectious diseases and in oncology, and so he'll be able to share from those experiences if we have clinical questions come up today. And then Dr. Elisa Bernstein, who's Senior Vice President of Pharmacy Practice and Government Affairs at APHA, is our subject matter expert on all things federal regulation and legislation. And she actually is going to share with us some really important updates as we get toward the end of our program today, based upon HHS's clarifications that they provided last week. Now, I want to go over a couple of ground rules for today and also our schedule for today's webinar. We'll have a conversation that'll last about 10 minutes with Dr. Varkey. Then we'll move to our conversation with Dr. McDonough, and then we'll open up the majority of the conversation today for questions from you that will go to both of our guest panelists as well as our regular panelists to the audience today. We really want you to go ahead and take time to type in your questions. If you look on the right-hand side of your screen, you should see on the GoToWebinar control panel a function where you can ask questions. You'll click on that at any point during the webinar today. When you have questions, go ahead and type those in. We will do our best to get to your questions. Sometimes we can't get to every question, but we'll do our very best to get to your questions and address those questions. Now, we like to let you ask your question verbally, but we need to get it in writing first so that we can categorize questions and sort of get the flow of the program going. Once we unmute your line for you to ask your question, you will have 60 seconds to be able to articulate your question and get your question out there to the panelists. So one thing that's important for you to do right now, if you haven't done it already, if you've joined us by telephone, you will need to be sure to insert your audio pin into the system in order for it to become unmuted when the staff unmutes you. If you have not entered your audio pin into your telephone, I'll call on you and we won't be able to hear you. And so we want to be able to give you the chance to speak. If for some reason you do not want to say your question out loud and you'd like for me to ask it for you, you can put a note in your question that says, ask this one for me. That's fine. I'll be happy to do it for you. So that's our approach. That's what we're going to do today. I want to remind you that there is a handout associated with today's presentation that you'll see in the handouts tab. And also today's webinar is being recorded. So you'll be able to access the recording at pharmacists.com following the webinar, and it'll be sent to all the participants within 24 hours of today's show. Now, without any further ado, I would like for us to invite Alex Varkey to activate his webcam and to join me here on the panel. Alex, welcome to our show today.
Hey, thanks for having me, Michael. I appreciate it.
Great. Well, you are the director of pharmacy for one of the largest health systems in the United States. Tell me some of your early observations about what was going on with pharmacists in Houston during the COVID-19 crisis.
Sure. So, yeah, first I'll just clarify. I'm actually the pharmacy director for the flagship hospital of one of the larger health systems in the United States. So I'm at roughly a 1,000 bed facility that's located in the Texas Medical Center, which is, for those of you not familiar with it, it's the world's largest medical complex with multiple different hospitals and health systems. We were really fortunate to have that close-knit medical community because it's allowed us to have a lot of early conversations about, infection control procedures, personal protective equipment strategies and things of that sort. And so we've had a lot of pre-planning as best as we could to kind of learn off of. But I will say, specifically from a pharmacist standpoint, I've been really encouraged, not surprised, but encouraged by how all pharmacy personnel, pharmacists, pharmacy technicians, student pharmacists, have proverbially run towards the fire, if you will. They just want to do anything they can to help our patients, working alongside our nurses, our physicians, our respiratory therapists and others, just to ensure that our patients have what they need. I think there's definitely a healthy amount of concern as far as any potential risk of exposure and bringing that back to their loved ones and their families. But I've just been so encouraged by how our pharmacists and pharmacy personnel are really stepping up to address the community need during this pandemic.
Well, you used a great analogy there about pharmacists running toward the fire, and I think that's we've heard that story over and over, that pharmacists have really stepped up, and that's very true. I wonder, how much direct contact in the hospital setting have pharmacists had with COVID-19 patients? Have your pharmacists basically been working away from the COVID-19 patients, or have they been in contact with those patients? Tell us a little bit about your experiences there.
Sure. So traditionally, our pharmacists do have a lot of contact with patients in general. So, whether it be during multidisciplinary rounds, whether it be responding to medical emergencies or code response, the med history process, patient education, discharge counseling, consents to clinical trials, those have all been things that our pharmacists have traditionally been involved as far as direct patient contact. We've had to implement some strategies to try to control some of that risk of exposure. And so we've had to rely on some telehealth strategies for, say, med history, patient education, things of that sort. But when it comes to code response and trial participation consent, there's still some direct patient contact that's necessary for those. Even in medical emergencies, we try to implement strategies like having the code card outside of the isolation room and having the pharmacist with the cart and handing in medications to the personnel that's actually by the bedside to try to help control some of that exposure and conserve PPE as best as we could, knowing that that's such a finite resource right now. But there is some direct patient exposure still that exists within our model.
You mentioned, Alex, PPE, and I think in all the weeks that we've been doing this webinar, probably the hottest topic we've had and comments from our participants has been around PPE. And we know it's been a big challenge in the community setting, but in the hospital setting, what challenges are you having at the institutional level with acquiring PPE, and are you able to get what you need for your pharmacists?
So to answer the second question first, yes, we're able to get what we need for our pharmacists. I think like everyone else, I think we've been managing through this worldwide PPE shortage as best as we can with what we have. Certainly had to implement conservation strategies like extending the use of masks as safely as we can. One of the unique things about personal protective equipment when it comes to hospital pharmacy practice, and certainly with our outsourcing pharmacies, is that you need PPE to properly prepare sterile compounds, IVs. And so, we've had to look at guidance from the CDC, from USP, other regulatory agencies to try to ensure that we're doing that as safely as possible. while at the same time being good stewards of that resource. Our access to PPE has been fairly extensive, I do have to say. I think our institution, as well as a lot of the institutions in the Texas Medical Center, implemented very early on a universal masking policy. And essentially what that is that any personnel, whether you are patient-facing or not as patient-facing, has access to at least, one ear loop mask per day while you're on campus. And that's to help, of course, protect our patients and also to limit any sort of exposure risks among our, interaction with one another as healthcare professionals. And over time, we've, as our county has implemented public masking policies and emergency orders of that sort, we've adopted similar strategies within our hospital and essentially providing and requiring masks as part of our uniform so that we continue to limit that exposure as states like Texas start to open back up.
It's been reassuring that you've been able to manage that and that you've been able to do what you need to do to take care of your folks, and that's great. I want to shift just a little bit. One of the things that we are hearing a lot about these days in hospitals is perhaps a shortage of opioids and pain management drugs. And I wonder if you could speak a little bit about any challenges that your health system may have experienced as it relates to access to opioids for, sedation or for pain management or whatever. Could you speak about that just a bit?
Oh yeah, we've definitely been, pushed with regard to our capability of getting adequate supply of opioids. Fortunately, we have not had any severe supply shortages to date, but I think that's a credit to a lot of the folks behind the scenes that are working all of the lines to try to figure out, how to get fentanyl, hydromorphone, some of these, pain management, opioids that we require for providing care for our patients. I think the unique challenge here is that everyone is dealing with this same disease state, and these medications are used for the treatment of patients who are not dealing with COVID-19. I think, looking back on the strategies in response to the opioid crisis, for example, where there were limits placed on production of these opioids, I think that might be a strategy that has proven costly in relation to our ability to treat patients adequately, either from a pain management or a sedation standpoint. And I know that the DEA has somewhat relaxed some of those limitations, but my hope is, as a lot of healthcare professionals are starting to think through, is there going to be a second surge as states start to reopen? I think it's certainly something that we are cautious about. And my hope is that any sort of relaxing of those limitations of quantities of production will essentially be able to meet the need on time as we need them. But that certainly continues to be a challenge we manage.
Well, and not only the quantities of production from the manufacturing standpoint, but I understand from some that there's even been restrictions of distribution from wholesalers, that's been a challenge too. Is that right from your experience, or?
So, I think our wholesalers are in, somewhat of a challenge because, they have, their organizations that they serve and wanting to ensure that everyone has access to these therapies. And so, yes, there's a lot of, allocation amounts, and, those allocation amounts are rarely enough in comparison to what institutions actually need from a daily and weekly and monthly utilization of these products.
Yeah. Well, Alex, I've got about 15 more questions I want to ask you, but we're running short on time. I want to be sure we get to audience questions. I'm going to ask you just one last question, and then we'll shift over and speak to Dr. McDonough. My last question for you is really about the well-being of your staff. You've got an awful lot of people that you're responsible for. Tell me a little bit about well-being and resilience of your staff in the hospital, and any tips or pointers you could give to everybody.
Sure. I have to say that we're extremely fortunate to be able to work in a place like this hospital, like Houston Methodist Hospital. I know that our hospital and our health system as a whole has done an outstanding job in supporting our team members. They've implemented several programs to support staff, whether they fall ill. There are support groups that they've opened up, not just support from a standpoint of just in general, with us needing support as healthcare professionals, but support groups for, employees who may fall ill and are recovering from COVID-19, so that they don't necessarily feel isolated. They can talk through, coping strategies and ways to just feel supported by one another. I think despite all of this, even our best efforts as healthcare leaders and as professionals, I think the natural tendency still is that a lot of us are suffering silently. We've heard about the unfortunate passing of the emergency medicine physician in New York, for example. And I think that's a cautionary tale for all of us. I think healthcare professionals, by and large, have been burning out prior to COVID-19. And so, that certainly goes for pharmacists and pharmacy personnel. And you add a global pandemic on top of that, and this is definitely something that is unbearable for a lot of people. And I think that with the stigma associated with mental health, people don't necessarily know that it's okay to not be okay. And I think that we as healthcare leaders and as peers and as colleagues need to do our part to be extra supportive of our peers and be there for one another. And so that, things like what happened in New York don't continue to happen, that all of us don't feel that we're alone in dealing with this on our own.
Yeah, well, it's a big issue. Well, Alex, thank you. And we'll be back with you. And audience members, if you have questions for Alex Varkey, please type them into the question panel so that we can start receiving those. Alex, we're going to shift over now to Randy. Randy McDonough, thank you for joining us today. If you'll activate your webcam, welcome.
Thanks, Michael. I appreciate being on here.
Well, it's great to have you here. We often hear about New York. That seems like that's the place in the news. And of course, New York is important. But what about Iowa? How has COVID-19 impacted your community and Iowa?
And I think it's interesting you talk about New York because that gave us a glimpse of what could happen, right? And although Iowa being more of a rural state, we were watching it very closely and trying to learn from it. We actually had a colleague who works at one of the hospitals there, and he provided a webinar for our state pharmacy association and provided us with things to be watching out for. So it did give us some preparation. Iowa right now is one of the states that you're seeing a pretty rapid growth in number of cases. And so we have started the reopening process with 77 of the 99 counties where it's a very restricted caution opening of some of the businesses and some more opening probably next week. But it has definitely restricted some of the businesses and their ability to provide services. For pharmacy, obviously, we're an essential business. What we've had to do is just adjust how we provide services to our patients, but still provide the services.
Yeah, well, could you expand on that just a little bit? I mean, what kind of precautions as a pharmacy owner have you taken to protect your staff in your community-based pharmacy?
Well, again, listening to our colleagues at New York City, we started thinking, what do we need to do? And we decided to make a move early on. So around mid-March, we made the decision to close down the lobby. And so we wanted to restrict any access of patients into the pharmacy. The whole reason for that is we wanted to contain as much as possible any virus from coming in. We want to protect our staff, we want to protect our patients. So we went to curbside delivery and home delivery as our main means. We still provide services because we still do some injectables for some of our patients, but it's by appointment only basis. Then we provide whatever protection we can for our employees because, again, shortages have been an issue. So we've had some volunteers who made some of the cloth masks for us. So everybody has to wear cloth masks. We have people wearing gloves. Again, if anything's coming into the pharmacy that may have virus in it, we want to contain it and then sanitize it as fast as we possibly can. And then creating policies and procedures for our staff so they understand what we're trying to do and they need to follow it, including sanitizing the workplace, the workstations as much as possible, like every hour on the hour. So it's just a new way of doing business, but still providing the same services to our patients that we always have.
Yeah, Randy, I don't want to certainly break any rules of confidentiality, but I'm just curious to know, have you been successful in keeping your pharmacy staff healthy?
We have, yeah, Michael. One of the things we had to do early on is we had 2 employees that we had to quarantine. One was their father is a primary care physician and did get infected, and she was at home at the time, and so we just said, okay, we got a 14-day waiting period for this. The other employee was someone who had gone on spring break, and we had surveyed all of our students who did go on spring break, and for the most part, most of them followed the social distancing. This particular one did say that I was in some crowds and we could not clarify, so we had her quarantined as well too. But otherwise, no one has come down. We do take daily temperatures of our staff, and they also have to fill out a 3-question survey before they can clock in to make sure they're not having any symptoms.
Great. Well, it sounds like you've been following those CDC guidelines, and that's a great thing. So now I understand that you specifically and your pharmacy practice got involved with your local emergency management agency early on. That's not a story I've heard told very often. Tell us a little bit about that, and maybe folks can take away some learnings from that experience.
Yeah, it actually happened early on. Again, kind of following the lead of what was happening in New York City, I just started thinking that if our health systems do become overwhelmed, there's going to be more spilling out of patients into the community. And what can the community pharmacist do to help with that process? So I started reaching out to several public agencies, including public health and social services, and to the Johnson County Emergency medical agency, and we were able to connect finally, and they did an interview to figure out how we could help them, and they thought maybe we could just create a separate group of individuals, of pharmacists, and have a call with them separately. But after we had the initial discussion, they felt like there was too much information and too important of information that they included me as their daily calls. So I'm one of the people now that gives them a daily report as far as shortages and services that pharmacists are providing.
Well, it sounds like a great connection to have in the community, great relationships. And, a few weeks ago, we interviewed Dr. Beth Bryan, a community pharmacist in East Tennessee, and she did share with us that having those relationships established with key public health figures probably did open some doors for her. It sounds like you'd have the same advice.
Yeah, absolutely. I mean, it's been good because they have not realized the impact that pharmacists can have. In fact, as I started talking about services and even the potential of being, a testing center, it was not something they even thought of. But as we talk about not critical access to medications, which we did talk about shortages and how we're monitoring that and managing it within our own pharmacy, it was also talking about the services that we're providing, especially for at-risk patients, to make sure that they're stabilized with their medications and monitoring them and providing regular communication to the other providers. Because that's one thing that was constant. We didn't miss a beat. We didn't stop seeing patients as far as in the way of doing medication reviews. We just had to do it differently. So we still did that. We didn't miss a beat, and we still provided the communication to the other providers. So we felt like we were the one consistent that continued on during this pandemic.
Yeah. Well, one of the things, Randy, that I've heard a lot in the news in the last few days is I think people are starting to realize that maybe our focus on the pandemic, which has been really important, has caused patients and providers to perhaps overlook the normal chronic underlying conditions that patients have that still need to be managed: diabetes, hypertension, mental illness, other things that require some pharmaceutical management. Has your pharmacy been able to maintain clinical patient care for chronic disease states, and how have you done that in this environment?
I appreciate that question, Michael. Yeah, that's the one thing I want to make sure we emphasize is we still had an obligation to provide those medication management services to those patients. And so, we just did it differently. Instead of face-to-face encounters, it was more telephonically. Telehealth and telemedicine is an option. It's not something we have the technology for ourselves, but we still had access to our patients through the telephone. So we still provided those services. We have several payer programs within the state that we are paid to manage these patients. And what's interesting, Michael, is that we were able to maintain all of our services during this time and meet all the requirements of the payers. So we're very proud of that as well.
Yeah, well, that's great, and I think that as we are struggling through nationally this process of trying to find a new normal, that's what I'll call it. Some would call it reopening. I just think it's trying to find a new normal. We have to recognize that pharmacists have this critical role to play in chronic patient care, disease management, and so forth. And I'm excited to hear that you've kept that pressing forward, and there's a path for that, and that's really great.
Yes.
Yeah,
Thanks, Mike.
great. Well, let me ask you one question that is very similar to a question that I asked Alex, because I think it's really a question that impacts us across practice settings, and that is access to medicines. And there have been drug shortages that have occurred across the entire spectrum of care. I wonder specifically again about opioids and controlled substances and drugs that you might need for palliative care in the outpatient setting. Has the COVID-19 pandemic affected that in any way? Are you having challenges with getting access to meds that your patients may need who are in pain, either at end of life or otherwise?
Yeah, and Michael, before I get into that, just quickly, part of the shortage is some of the drugs being used to treat the COVID-19 as well, right? And
Right.
For example, hydroxychloroquine, we have multiple patients that are using it for, actual indications such as arthritis or lupus. And all of a sudden, we saw that the shortages were coming down the road, and we started seeing prescriptions being written for COVID-19, and sometimes more as a precaution, prophylaxis, and not really have someone who has the actual COVID-19. So we had to make a decision very quickly, and we made a policy saying that we were only going to reserve it for our patients who actually have the indication outside of COVID-19, and that only 30-day supply until we knew we can get on top of the shortage. And that's been managed successfully. We never went short. We are a hospice pharmacy, so we provide a lot of palliative care, and we started seeing that some of the things they were seeing within the hospital system was also happening within the community pharmacy. So my take on that is just be proactive. We knew it was coming, so we were proactive. We started calling the stakeholders, the other providers, letting them know what was going on, provided options, alternatives, and talked about how we can manage this. And so far, we've been pretty successful. The most recent thing has been the allocation of some of the opioids. And we did run into that this past month, and we did request an allocation. So that was just an added thing we had to do, is now work through all those obstacles to figure out how do we get increased, because we are seeing increased use of these products. Absolutely.
Yeah, I'm going to ask you one other tough question here. I think one that you may feel fairly passionate about, and this is going to be our last question because we're running close on time. You are involved as a lead luminary in CPESN, the Community Pharmacy Enhanced Services Network of America. You're the lead luminary, and you're also a luminary for Southern California's program, and so we're excited that you're doing that. As CPSN and looking at things nationally, I'm hearing a few stories about perhaps PBMs not necessarily being as cooperative as they need to be, and having maybe created additional barriers during the COVID-19 crisis. In about 3 minutes, can you give us a summary of what's going on there?
Well, what I will say is that, financials are really important during this time, right? You got the legal, you got the professional, you got the financial. So we were watching reimbursements throughout this pandemic, and initially everything seemed to be smooth, and we weren't running into issues. But more recently, we saw one of the bigger PBMs in our state with one of our major payers. We started seeing a reduction, and not just a little bit of a reduction, but a pretty big reduction, and that did not sit well with me because of all the things we're doing within this pandemic to make sure continuity of care was still being provided. So that was pretty upsetting. So at this point right now, what we're doing is we're monitoring it and looking at the trends, and then making sure we're keeping in contact with our state association, because they've always been good about passing that information on, and seeing what we can do to try to address this. But this is not something, it's frustrating because we've done so well of making sure our patients' needs are being met from a pharmacist perspective, and then to have something like this, where if anything, payment should have been increased to decrease reimbursement to the pharmacist during this time, that's just not right.
No, you're right. It's not right, and I frankly believe enough is enough. That pharmacy as a profession has to draw a line in the sand on this. And I appreciate the work that you're doing, Randy, with CPSN and also with APhA. And thank you so much for that. Now I'm going to invite both of our panelists to activate their cameras, both Alex and Randy, and we're going to start taking questions from our audience. Remember, if you want to be able to ask your question verbally, you need to have put in your audio pin into your phone if you're joining us by phone. And of course, just unmute your line when the time comes for you to speak. If you're speaking over the telephone, we'll maximize the number of questions we can receive here by limiting our question time to 60 seconds each. And we'll take all the questions we can take until we have to turn it over to Elisa Bernstein for some additional commentary on some late-breaking news with the Department of Health and Human Services. So we'll start out with our first question, which is from Murti Savitala, S-A-V-I-T-A-L-A, Murti Savitala. Staff, if we could unmute Murti's line, we'll let this question come.
Thank you. I just want to know if we need to be tested for our COVID before all this all settle down.
Yeah. So the question here is, do pharmacists need to be tested? What are the protocols? Let's ask this question from three different perspectives. The community pharmacy and hospital pharmacy perspective. Alex, tell us about your hospital. Is there a plan for all healthcare providers to routinely be tested for COVID or have antibody tests for COVID at some point? What is your hospital planning?
So I think the closest thing to that we have in place currently is that we have started surveillance testing. And for those that aren't familiar with what surveillance testing is, it's when you test folks without necessarily having present symptoms of the illness. And so we first started doing surveillance testing of patient care providers, including pharmacists that were working on COVID units within the hospital. And we've also started doing testing of folks who aren't necessarily patient-facing, but still working within the institution. Right now, our percent positive has been 5%, and I know that that's somewhat lower than some of the other percentage positives that we've seen with surveillance programs in other hospitals across the country. Not sure if that's because of a multitude of factors like our universal masking policy and some of the other things we've tried to do to help limit exposure. But I think based on that, we know definitively that we're dealing with a disease state that presents differently in different people. And, it's not necessarily going to look like a moderate to severe illness. It can be very mild or completely asymptomatic. And so I do think that getting to a point where, all healthcare professionals are being tested so they can have that peace of mind and knowing, where they stand in all of this is probably beneficial. Certainly need to see the amount of opportunities for testing to open up to be able to facilitate that, but certainly feel fortunate that we do have that opportunity here. Sure.
Randy, what about in the community setting? What are your thoughts about this or approaches in the future?
Yeah, I think that's a good question, Michael. That's one thing I got to tell you, as I look at this, that's the one thing that's been the most difficult thing to wrap my head around is the testing as far as from a community pharmacy perspective. I'd be interested in the serology testing, the antibodies, to find out, have you built some immunity? But I'm not sure we're there yet with the tests. What's out there? Do we know what they're actually telling us? Do we know what the system is for feeding that information in? But I do see this as an opportunity for pharmacists to be involved in, but they need to make sure that they're fully informed. They've done the due diligence, understand how to do it, and what the information means, because they're going to be one of the providers that people will be coming to because of their accessibility.
Yeah. Well, testing is, again, one of those top questions we get week after week on this program, and I think there's still more questions than there are answers, unfortunately, about testing, so we will have to just keep pressing on and sharing information as we have it, and we'll definitely do that. Now, the next question I have is actually one that we received just before the webinar started from one of our attendees who submitted an in advance question, and this question is for Alex. Alex, we've learned this week that remdesivir has been allocated by the government, and what in the world does this mean? Can you tell us a little bit about access to this drug therapy that's showing some promise in the treatment of COVID-19, and then maybe some of the challenges you see with that at the hospital setting.
Yeah, certainly. We're fortunate to actually have experience with remdesivir in treatment of our patients here. Fortunately for us, one of our infectious disease pharmacists, Catherine Perez, reached out to Gilead pretty early on in sort of investigating availability of product for compassionate use, and the ball started rolling from there to where we eventually were enrolled in 2 of their phase 3 studies. And so we have been able to acquire product for study patients, for patients that consent to the study. And I think what you're alluding to is that late last week, or I should say around May 1st, remdesivir was approved for emergency use approval, and so or expanded use, and so Gilead has provided product to the government to distribute for that purpose, so that more patients can take advantage of what is starting to look like a promising therapy option. But I think one of the frustrating points about that right now that a lot of health systems are dealing with is that there's not a whole lot of information regarding which institutions qualify, which ones don't, what the qualifying information is, what's being considered. And so I think because there isn't a whole lot of transparency and a lot of information out there for people to grab onto, I think there's a lot of concern about ensuring that our patients have access to this therapy. We realize that there's obviously not enough, from a production standpoint, to go around for everyone to have access to it. But I think we're all kind of starving for some more information on how to put our communities in best position to take advantage of what's available.
Yeah, I'm reminded, because of this situation that's been put in place the last few days with remdesivir, of the law of unintended consequences. The unwritten law that says that even when you try to do good and you try to have something positive happen, there are unintended consequences related to that, and you got to think ahead and think through what the unintended consequences are of taking what may otherwise seem like a positive action. And so that requires a lot of thinking on your feet as hospital directors and owners. You got to think a lot about those sorts of things. Let's take our next question from Griff Danheim. Griff Danheim, D-A-N-H-E-I-M. Griff, we're going to unmute your line.
Line's open.
Go ahead, Griff.
Hi, good afternoon. Can you hear me okay?
Yes, we've got you. Go ahead.
All right, very good. Hey, thanks for all the great work that y'all are doing during this pandemic, and certainly pharmacy is on the front lines of not only the solution, but for care of a lot of people. I work with Quidel. We're a global diagnostic company, and I work to develop the point-of-care testing market in community pharmacy. And over the past several years, we've had growth across the country in this practice addition for community pharmacy, most recently in Florida. And so my question is, how do you envision the change in the practice of pharmacy for point-of-care testing with the advent of COVID-19? Certainly we'll have an antigen product out very soon, but from a longer term standpoint, do you see this being similar to the big push when we had H1N1 and all of a sudden, immunizations just went through the roof in pharmacy practice? Do you see this as kind of a touchstone for point of care testing? Thanks for your answer.
Yeah, great question, Griff. Randy, what are your thoughts on this?
I do. I tell you, my concern, and I shouldn't say a concern, but the questions I would have is just, as the tests evolve, do we really understand what the tests are telling us, and can we provide good information back, and what's the system for that information? I do think there's a lot of potential for it, and the question I would have is, does it happen in relation to a vaccine, where you're doing the testing in the vaccine, and what's the information telling you? So I am very interested in monitoring this. We've got quite a few people at a CPSN USA, who are looking at this on a regular basis, some of the experts within the testing. One of the people that Michael interviewed a couple of weeks ago. And, right now they also are having some of the questions and knowing what does this tell us and things like that. So I think there's gonna be a lot of opportunities for point of care. I don't know what it looks like yet. but I am a CLIA waived lab. I have been since probably 1997. So we do a lot of point of care testing, and I see this being an extension that I think there's an opportunity, especially as it relates to make sure we're vaccinating people as well.
Yeah, I will just add to this a little bit in that, and knowing a lot of APHA's work in this area, that we do see a lot of increased activity related to allowing pharmacists to do point of care testing. I mean, I think we've realized that our healthcare system is going to be radically different following COVID-19, and there's no question that pharmacists have proven themselves as essential providers of healthcare service. And in rural communities across this country and in urban areas across this country, pharmacists must, in fact, do the things that you're describing, Griff, in your question. They must do this point of care testing. They're going to have to initiate therapy based upon the results. They're going to have to communicate with the healthcare team to provide follow-up and responsible, accountable care on the other end. But also what has got to happen related to this is there has to be payment to the pharmacist, and we have to integrate the pharmacist fully and completely into the payment system to be able to allow that to happen. So it's not just about the testing authority, it's also about the payment, and that's a really, really critical thing. So, okay, I'm going to move on to the next question. We've got tons and tons of questions here. So there's a question here from Adrian Wilson. Adrian Wilson, W-I-L-S-O-N, for Randy. Okay, I think Adrian may be taking care of a patient, so I'm going to ask Adrian's question. Are there any different precautions your staff are taking to continue provide vaccinations or other injections? So are you still doing immunizations, Randy, and what other precautions are you taking?
Well, as I said, one of the things we continue doing, and it actually increased because we had one of our group homes where the nurse was not able to do injections of long-acting antipsychotics, so we saw an increase in that. As we looked at our patients with immunizations, that they didn't have to get immunized at that point, we tried to hold off, but we did still provide some Shingrix for our patients. So it's got to be by appointment. We want to make sure we reduce the amount of patients within the pharmacy, and as we reopen our lobby, we're going to be doing the same thing as well. We survey them as far as any symptoms they might be having, so that if they are having symptoms, we hold off. But if they say no to all that, then we make sure that the pharmacists have the PPE that they need, at the very minimal, making sure that they are masked up and they've got gloves. We don't have a lot of other PPE, but we do have some gowns. And then we also was able to secure some face masks from one of the local manufacturers in Iowa. And so we also will be doing the face mask as well too, to make sure that we just protect ourselves as much as possible. So it's just taking precautions, making sure you're being proactive, asking the right questions, and then just making sure that you're keeping the pharmacist safe and containing the virus if it does come in.
Yeah, and we've gotten a couple questions about immunizing during the COVID pandemic, and I just want to point our listeners to the CDC's website, where there is some guidance about what you should do for providing preventative care services for adult patients during this time, including immunizations. We have a link to that webpage on the pharmacist.com website. If you click on the COVID-19 link at the very top banner on pharmacist.com, you'll be able to find a link to that CDC information, and hopefully that'll provide clarification for those of you who have questions about it. Now, I have a question that's been submitted by a pharmacist who's international, an international pharmacist, Luna El-Bizri, and she's asked me to ask this question for her. The question is, for cancer patients or chronic patients, are you delivering medicines to their home? Is that your primary strategy for making sure that immunocompromised patients don't have to interact with the community? Is that how you're approaching that? And so, Randy, you answer that first, and then Alex, I'm going to ask you a related question to that.
Yeah, absolutely, Michael. That's exactly what we're doing. For those patients who are at risk, and we talked about those at-risk factors for these patients, we want them to stay at home. and we'll take care of it, and we'll manage them and counsel them and educate them telephonically, and then make sure they get critical access or access to the medications. And so we had to do new policies and procedures for our delivery drivers too, so that there's still that social distancing. But yes, it's all delivery to their homes as much as possible.
Yeah, okay. Well, my question to you, Alex, is what are you doing about taking care of hospitalized patients who are not sick with COVID, but are hospitalized because they need to be hospitalized, perhaps for cancer, or maybe they've had a heart attack or other things? How are you caring for patients in the hospital in light of COVID? What's changed?
Several things have changed. You know, the first and probably the biggest thing that's changed is that we have paid a lot more attention in the control of traffic in and out of the hospitals. We have screening stations at each of the open entrances into our health system or into our hospital, and we've also instituted a policy where the number of visitors that are allowed has been significantly reduced and eliminated for a lot of areas, limiting those to really essential visitors. And so that in of itself has, I think, reduced some of the exposure risk and associated with such a highly contagious disease state like with COVID-19. We try to provide the same level of care as we always have for our non-COVID patients. And so, when it comes to hematology oncology, for example, our infusion clinics, which are on the other side of the street from the main hospital, those are still open. We have open communication with patients as far as what things we put in place to try to significantly reduce or eliminate risk, to put them at ease and ensure that they're safe. In the administration of those therapies, we have still seen some of that volume, decrease from rescheduling and things of that sort that have happened as a result. But we're still here and ready to provide care for our patients as needed, whether COVID positive or not. And we're doing all we can to be as cautious and as safe in administering that care as possible.
That's great. That's great. Now we have a question on the line from Dawn Wagoner. She has a question for Randy. Wants to get Randy's opinion on something here. Dawn Wagoner, Wagoner.
Line's open.
Line's open. Dawn, please ask your question.
Yes. So, in your opinion, at what point will you be comfortable going back to the open door format of your business?
Yeah, that's a good question. We just had our clinical meeting today where we were discussing that, and we're putting some policies together for that right now. To be honest, I think what's going to happen in Iowa, we've got 99 counties, 77 have been opened, and there's going to be some more businesses opening next week. Our county is not one of those counties. We're part of the 22 that's still under the more stricter regulations. As soon as they lessen that, I think we need to be open. But we need to restrict as far as number of patients in the pharmacy. So we've talked about how we're going to do that. We're putting some signage up, how many patients can be at the pharmacy at a time, and we'll still provide the curbside delivery. But I see once the governor releases some of the restrictions within our county, that's when we'll do it. So I'm following what the public agencies are suggesting with that.
Okay. Well, guys, this has been absolutely phenomenal. What a wonderful bit of knowledge that you have shared with your colleagues. I wish we had another 2 hours, because we've got another 2 hours worth of questions that have been submitted that we just can't get to today. But I'm going to move us forward. Thank you both for joining us for today's presentation. Now, to our attendees, don't go anywhere, because we do have some late breaking news that we need to share with all of you. First of all, I want to get just a real quick feedback. We're going to take 30 seconds and ask a polling question. I would like to know from all of you, this issue of opioids and drug shortages was one that we brought up. Have you experienced challenges related to procuring or obtaining medications for pain and palliative care during COVID-19? If you could just quickly vote on this one and let us know that you have or haven't had challenges, it'll help APHA staff as we're doing advocacy work to understand where your challenges may be. So we'll quickly get your responses in here and understand what your opinions are on this. Okay, let's get the poll results. Quite a number of you responded. Now, a good number of you on the phone today are not providing care for pain and palliative care patients. Some of you have had some challenges, about 20% of you, and some of you have not. So thank you for that insight. That's very helpful. Now, what I'd like to do is turn it over to Elisa Bernstein, who is going to share with us some updates on some recent HHS activities. Elisa, the floor is yours.
Great, thank you. So as you heard from us a few weeks ago and from the news that HHS authorized pharmacists to order and administer certain COVID tests. Well, last week, CMS released new regulations also addressing pharmacist testing and patient care services during the COVID pandemic. I'm going to focus specifically, because of time, on the testing provisions. And really what they said is that COVID tests can be covered when they're ordered by any healthcare professional, so that includes pharmacists, if they're authorized to do so under state law. And Medicare said that they will pay for COVID tests performed by pharmacists as part of a Medicaid enrolled laboratory. So a pharmacy needs to have an updated CLIA certificate and be enrolled in Medicare as a pharmacy to bill for laboratory tests to get coverage for this. Flu and respiratory virus tests that are performed in conjunction with COVID diagnostic tests are also going to be covered by even on an order of a pharmacist. And if pharmacists are performing clinical services, they can only bill those under a contract with a physician or other practitioner under Incident 2 for Medicare beneficiaries. So APhA, along with other pharmacy organizations, we're meeting with CMS in about 10 days to pose questions about implementation, billing, payment. We know that this raises a lot of questions for you. We're going to help get those answered. And in the meantime, we're also working to provide some specific guidance on implementation. However, without an avenue to directly bill pharmacists for their clinical services, the widespread testing that the administration envisioned is just not going to happen. So CMS was constrained by the current law when they developed these pathways, particularly why the Incident 2. We believe legislation is needed to make this work for you and to provide greater access for pharmacist testing. And we're calling on Congress to amend the Social Security Act to authorize pharmacists as Part B providers of pharmacist testing services to enable appropriate direct billing for these services. At the same time, it's important for you all to know your state scope of practice guidelines and what you can do related to testing. So some states have a very restrictive scope, and NASPA and the state associations across the country are advocating for broader authority and reduce those barriers. So I urge you all to work with your state associations to mobilize change in your state. Going to the next slide, going back to the legislation, we want you, can you go to the next slide, please? Yeah, we want you to send letters to your legislators urging them to include this in the next COVID economic stimulus package that Congress is right now considering and will vote on very soon. APhA has a website that makes it super easy for you to send these letters to your legislators. You just enter your zip code, it pre-populates letters that you can send, or you can make them. You push a button and it goes email directly to your legislators. It's really easy. So go to actioncenter.pharmacist.com to send your letters today. I'm going to turn it back. I think I'm done. I'm going to turn it back to you, Michael. Thank you.
Great, thank you so much. I appreciate the information that you've shared with us today. There's certainly a lot going on. It seems like that every day something new is happening. Well, I also want to share with you that APhA is continuing to work on several other things, not just this advocacy area, but some other things that you will find helpful for your practice. Last Friday, a new update was released on a new CE. 15 to 20 minute CEs are available. We call them APHA's 15 on COVID-19. They're done by Dan Zlott, and they're fantastic, short, brief overviews of the emerging clinical topics. And this week we have vitamin C update and a remdesivir update, and I've participated in both of those already. Well, the vitamin C update, you may have another new remdesivir one coming up, Dan, but these are great, and I would encourage you to take a moment and learn from these. I also want to just share with you that there are a number of practice resources available on the COVID-19 webpage. I would like to just point out a couple of others that you may have not seen before. One is about optimizing your health system pharmacy practice during the COVID-19 pandemic. Lessons from the field on preparing and adapting your health system pharmacy in the COVID-19 crisis, and we think many of you will find that to be quite helpful. And again, I want to just emphasize to you all, we want your feedback. We want to hear from you what's working, what's not working. Tell us your experiences, and that's the point of the next slide, which is our Engage platform. Folks, we really do want to have you engage with each other and engage with the association. Post your questions, share your lessons learned, support each other, get the latest information on Engage. Now, on the Engage platform, we try each week to pick one or two of the questions that we received during the webinar that week that we didn't have a chance to get to, and we provide a response to those questions. Unfortunately, we can't answer every single question because we get so many, but we'll pick a couple of those and we'll answer them there. So it's a good way to carry on the conversation from today's webinar and continue to engage with your colleagues on a day-to-day basis. I'm also very excited to share with you that next week we have a very special program scheduled, same time, same day, same place. We will be talking about pharmacist professional well-being, and we know this was a hot topic way before COVID-19 hit, but it is an especially important topic now for us to talk about the well-being of our pharmacist workforce. And so pharmacists, student pharmacists, pharmacy technicians, we're really wanting you to be on this call. We encourage you to let your colleagues know this is a show they will not want to miss. This is about their well-being, so they need to take an hour and listen in on this. Dr. Ken Duckworth from the National Alliance on Mental Illness, NAMI, will be sharing with us. NAMI has a host of resources available, and they're partnering with APhA to be able to help address issues of well-being. And we think you're going to really enjoy next week's program. It will be personally fulfilling for you, we believe. Again, thank you for all that you do on behalf of the profession, on behalf of the communities that you serve. We are so proud of you and your work. Pharmacists, student pharmacists, pharmacy technicians, you are our healthcare heroes. Thank you, and God bless.